Anthony Gitau is the Director for Global Community Impact for Sub-Saharan Africa at Johnson & Johnson. It's a real pleasure to have you in the discussion today, Anthony. Thank you for being a part of it.
Thank you, Raj. Nice to see you again.
Yeah, nice to see you too. And I was pleased to read your contribution to the Duty of Care series. I read your piece. You did a Q&A with one of our reporters, and you were really zoning in on this issue of silos. And how do we break down the silos in global health, and thinking specifically about community health workers. Can you tell us a little bit more about what you meant by that and what that's all about?
Yeah, the problem, Raj, is that a lot of the healthcare system, especially the funded healthcare system in developing world, is really structured in silos. So it would be HIV, TB, malaria, maternal and child health, reproductive health, and so on. And therefore, any resources coming into the system sort of comes down through a silo of either HIV or TB or malaria. And at the end of the day, the health system needs to respond in, so if it's a community health system, it's one community health system that you have one community health worker that goes into this number of households, and they must look at the health of the people. But because they're funded to do HIV, you might find that they focus more on HIV programming, or they focus more on TB contact tracing or malaria. And what happens then is that you have some areas that are over-resourced because the vertical programs are focusing there. And you have other areas in the community health system that are under-resourced because they probably are not a priority area for investment. Now, what that does is then you have an imbalance in terms of how the community health or the primary healthcare system looks from one part of the country to the other. And my call out for this was that why don't we look at the primary healthcare systems and community health systems especially, and invest in it ubiquitously, right? So that if you have a community health system in village A, it looks exactly the same as village B. And I think in this pandemic situation, we've seen how important that would have been if we had that equitable kind of spread of resources.
And it seems like this could be a wake-up call for that moment. I did an interview with Mark Dybel during the beginning of the pandemic, and he was describing how he thought maybe this was a chance to get the software platforms that are often provided to community healthcare workers, an app for HIV tracking, another app for some other disease area, because people are stuck in these vertical silos, that maybe this was a chance to break down those barriers and have everybody equipped with that smartphone, with connectivity, with a single kind of healthcare environment where you could track disease issues across areas with one individual patient that was more patient-centric. Are you seeing, in your experience now in the region you work in, any progress on these issues of breaking down those silos, for example, when it comes to software or other kinds of training or other programs for CHWs?
Yes, we're starting to see that. So in Kenya, we did launch the community health units for UHC in an effort to try and address exactly that. Because as we were co-creating this community health worker platform, that is part of the problem that we realized, that sometimes we might find that one community health worker has 6 phones, each provided by a different program. And then you have another in a county nearby that has absolutely no phone. Because they are all provided from those parallel programming. So why don't we spread these 6 phones among 6 community health workers that need it, but have only one system that they are working on, that then each different vertical program is able to pick their data from and is able to train these community health workers what they need done to be able to ensure that then you're really strengthening the system to respond to all these healthcare needs. So the way we look at that is we need to bring everyone together, and it starts from the top. It really can't be fixed from the community health worker or the community health unit perspective. It must start at the national level, where the programming is being designed, where we are putting together how this is going to work. If then you look at community health as a tool to provide service across the programs, and everyone is buying into this one service, then you then start to break those silos right from the beginning. And our challenge was to try and bring everyone in one platform that then looks at one plan for the country, works together to achieve it. And in that way, you also harness the strength of each different partner to be able to deliver on this.
And this is the new acronym. You know, global health is filled with acronyms. This is an exciting one because it's actually a palindrome. I was amazed to see it. CHU for UHC, right? This is the community health units for universal health coverage that you lead and are part of in Kenya. Yeah, tell us more about that new acronym, that new platform, and what it's for.
So the CHU for UHC platform speaks to exactly what I was saying just before this. It's really looking at this. The community health unit is a basic unit of provision of community health services at the lowest level, and usually composes of about either 10 to 20 community health workers that are working, reporting into a primary healthcare facility. And the reason why we thought that we need to have that as a basic unit of focus is that if you then strengthen a community health unit, then you strengthen the basic unit, and the community health workers under that then are properly supported. They have the right resources, they are formalized into the system, and are therefore working together to be able to improve the health of the households that they are supervising. And that usually covers about 5,000 people in Kenya. So the reason why we brought this together is to say, what if all we who are working in a county in Kenya, for example, or in Kenya, then focus on that unit and say, what is it that this unit has to do to improve? And what we do use is, for example, the community health worker assessment and improvement matrix that is championed by the Community Health Impact Coalition, is to assess what your current status is. Once you have that assessment done, you then put the requirements to improve it to where it needs to go. And then using that method, then you have a continuous process of improvement that then gets you to the ideal scenario of where you want to be. But the main thing was to start that conversation of saying, hey, let's sit together. Let's look at this as a common challenge and work on it together. And one big success I would say that came out of this is that when COVID-19 hit in Kenya and the ministry looked to community health, the CHU for UHC platform partnership came together and actually developed a position paper that then was used as a basis for what exactly should community health workers, what role will they play in, and how will they be protected and trained in being able to provide COVID-19 services. And this was done together, and that's what we really want to achieve.
It's seeing the community healthcare workers in these units more as a system as opposed to a project, which is so often the way they're utilized. There's a pool of funding that's available for the next 3 years for a project in nutrition. Let's bring a bunch of CHWs together and train them on that and send them out. And instead, you're saying, let's actually have a systemic approach where these are community healthcare workers who are trained and are patient-centric. And they can work in nutrition, sure. They can work in HIV. And when there's a pandemic, they can work on COVID. And that is a different way of thinking about this. And it's not the case in every country in the world. Another big challenge that came up in the last conversation, I just want to get your take on it, is basic compensation for healthcare workers, including CHWs. Why is this still such a big question? Why has this not been dealt with? What is your take on this issue of compensation for healthcare workers?
I believe and COVID-19 is actually showing us that what we've been championing so far, and everyone sort of is always fighting against the allocation of more resources to healthcare, is because they look at it as a healthcare issue. But what COVID-19 is showing us that actually lack of investing in healthcare systems, especially primary and community health systems, is actually an economic issue. I believe what Dr. Anyesa just said in the previous panel speaks to that. Because of the investment that Rwanda has made at the primary healthcare level, that is why they've had a much better response, because then you already have an existing system that works, and all you need to do is activate it for pandemic response. And secondly, you then have the community trusting it because it works. However, if the community doesn't trust the system because it doesn't work, and then you have a pandemic and you now come in and you're telling people you must listen to what we're saying, it causes a sort of a disparity in how this is going to happen. Some will trust and some will not. And that is part of what I feel the challenge is, because it's always looked at, we have a budget for health, and of course, every country has been committing, for example, to the Abuja Declaration to get to 15%. Most countries are not even there yet. But the challenge is that we do a top-down budgeting where we have the whole pie, then it is cut into certain pieces. And when the healthcare piece is given, then it's seen that a big chunk of that is going to human resources for health. So if you ask anyone, they say, yes, but a big chunk of our healthcare budget is going to human resources for health. But how much of that is actually addressing the need that is there? That is the key question. And so the best that a country would do is to really start from the bottom up and say, this is what we need for a primary healthcare system, for our health system to be able to be functional, and then fight for that budget, as opposed to just getting a piece of the pie. And I totally agree that I believe strongly it's a legislative thing, because if you leave it to the budget to be done by the time the law is already in place, then that's what's going to change. But if the law already dictates that this is what we need as a basic minimum for a health system, then we start moving towards the right direction.
Yeah, this is Anya's point about looking at parliaments, not just ministers of finance. We're running a little short on time, and I wanted to get to a couple of other points with you, if I can, Anthony. One is around this idea of a scorecard that I know you've put out there in the past. The idea that you could rate countries and the way that they operate in their health system one against the other. Tell us more about the scorecard idea.
So this idea, Raj, comes from our Center for Health Worker Innovation at J&J, where we're trying to look at that frontline health worker at the center of our solution. And when you look at a frontline health worker, it's really looking at issues to do with training and education, leadership and management, well-being and resilience, connection, integration into the system, and most importantly, respect and recognition. Now, for us to be able to see whether we are improving the lot of the frontline health worker to get to the next level where they're efficient and are happy in the system, we need to be able to be accountable for it. And the way I've seen it, and it works a lot in the private sector, is a scorecard that measures you against your commitments to where you want to be, and a publicly accessible one, where even your population is able to look and say, well, Kenya committed to do this, where are we versus that? Where are we in terms of status, and how are we progressing towards getting to a better place? And that will then make the frontline health workers work with you as the government, as partners, and everyone else to come together towards really ensuring that you're able to get to the next level in terms of having well-supported frontline health workers in the country.
Yeah, in a way, the worst kind of scorecard is what we're seeing today, where we all go online to check the latest statistics on how many COVID cases in each country, how many deaths, and you can score and see how countries are doing on things like mortality and spreading and testing. And that's kind of the worst kind. We want a scorecard at the way you're describing, Anthony, where we can see in advance what does a great health system look like and make sure we can all invest in that. We've run out of time, but I want to ask you for kind of your last thoughts and call to action here. We've got global health leaders participating in this event from all over the world. What do you want to say to all of them as we wrap up today?
Thanks, Raj. I think what I would say to everyone is that we need to strike while the iron is hot. We need to act right now when everyone everywhere appreciates the role of frontline health workers. It is a dream for all of us who've been campaigning for this frontline health workers and for the Center of Health Worker Innovation. For us is to say, how do we take this momentum? How do we convert it into credible and trackable actions to make sure that we have frontline health workers supported, so that we have health systems that are ready to respond to such pandemics, but also in normal times? Because as I said earlier, it is not just a healthcare situation, it's an economic situation. If we strengthen them, then we wouldn't be too worried about how we are responding to any pandemic coming forward.
Well, thank you so much, Anthony Gitau, for your leadership on these issues, for the Center for Global Health, Health Workforce Innovation, which we've been tracking since it was started here at Devex, and I think is playing a really important role in this space. And to J&J for their partnership, longstanding partnership with us at Devex and with the global health community, and on today's event, helping to make it possible. Thank you very much for being a part of this discussion.